I'd just like to introduce myself. I'm a registered nurse, asthma and respiratory educator. So I work in respiratory clinics in a couple of general practices here in Melbourne and have done that for many years now. And I'm one of the clinical consultants at National Asthma Council that helped put the Asthma Best Practice Education Program together. So let's see how we go. So these are the topics we're going to talk about today. And just really a bit of an overview about asthma, pathophysiology, triggers, diagnostic principles and management principles. We will, of course, talk about adolescents and asthma. We'll talk about the current guidelines for asthma management, written asthma action plans, and cover acute care for acute medical management for asthma in primary care. And then just a little bit at the end about asthma and COVID-19, of course. So our learning objectives, there they are. We have to have learning objectives, and we do ask you about how these are met in the evaluation. But of course, tonight, my main priority is to make sure that you get the information that you want. And so if you feel that that's not happening, that's where your questions are. Over it, there's the topics that we're covering today. Here's the learning objectives that we're covering today. As I said, please ask your questions as we go along. That's very important to us. So just a little, update on the Australian Asthma Handbook. I hope you're all really familiar with this website. The handbook is a completely online resource. It's free and available to everyone within the world, of course, on the internet. That's the address there, www.asthmahandbook.org.au. All of the presentations that our National Asthma Council present, whether they're face-to-face or webinar versions, are based on our Australian guidelines, of course. And it's really important to us that everyone in primary care, everyone looking after those with asthma has access to the guidelines. So I encourage you to explore the website. It's got an excellent search function there that you can see. So if you're not familiar with it, please take some time after the presentation or when you can to explore that website. You'll find it really worthwhile. The National Asthma Council also has a really comprehensive website. Once again, really hope you're familiar with this one, but if you're not, there it is, www.nationalasthma.org.au. And there's sections for the community, sections for health professionals, lots of resources available, and many of the resources that I talk about in tonight's presentation are available on the website there. Our office in Melbourne was closed all of 2020, so the resources needed to be downloaded by yourselves and printed. But we have recently just recommenced a couple of days a week back in the office, so you are welcome now to order resources online and they will be able to be posted out to you in hard copy. But all resources are printable from wherever you are, so please take advantage of that as well. So just a little update about asthma in Australia. It's really great that if we're all on the same wavelength when we're talking about asthma. So it's a very prevalent condition in Australia. Over 2.7 million of us have asthma. That's about 1 in 9 Australians, which is quite high by international standards. There has been a decline in asthma since the early 2000s in children and young adults, but stable in those over 35 years. And my personal view on that is because we're much more particular about diagnosing asthma in children now, Pediatric Diagnosis, and that's another webinar topic. Asthma is more common in boys than girls, but after adolescence, it's more common in women. And the death stats there that were released in 2009 were actually an increase from the previous year. So 421 people died from asthma in 2019. And sadly, the largest increase was in women aged 54 and under, and those aged over 75. So we've still got some work to do there around the death stats. About 50% of people with asthma over 75 years of age have not actually been diagnosed. And we'll talk about that a bit later on in the presentation, but largely because people in those older years often just accept those symptoms as getting older. So they think they're a bit more short of breath or not able to be as active as they were because they're aging, and that's not always the case. And the flip side of that statistic is that reports from around the world show that 25 to 35% of people with a diagnosis of asthma may not actually have asthma. So once again, we've got to be really aware of our diagnosis and making sure we've got that right and we're treating the right condition. So just a reminder, what is asthma? It's a chronic lung disease. It can be well controlled, but not cured. And, you know, a lot of folk talk to me about, will I grow out of asthma? Will my child grow out of asthma? And in fact, really, we understand that the inflammatory processes, once that's triggered, can be stabilised and maintained, but that can recur at any time in life. In clinical practice, asthma is defined by the presence of excessive variation of lung function and variable respiratory symptoms. And when I read these quotes, it always makes me think about, you know, what does that actually mean? And to us as health professionals, it makes a lot of sense. Variation in lung function, we measure with spirometry, and we can see that. We can measure that with peak flow. And spirometry, we can do pre and post bronchodilator spirometry to see variation in lung function. But for people that suffer from asthma, variation in lung function means they have good days and bad days. We want them to have well-controlled asthma, so we want them to be able to do all of the activities that they want to do without their asthma affecting them. But that's not a reality for most people. And variable respiratory symptoms means they come and go. So the symptoms of asthma are there one day, maybe not there the next day. Maybe people know why, maybe people don't know why. But once again, that leads us to that place where people become a bit complacent, perhaps ignore those symptoms, or don't actually get those symptoms followed up with a medical practitioner. I always really like to show this slide because it's a really great reminder that asthma is a disease of the small airways and causing obstruction to the small airways. So the narrowing of the airways is due to inflammation of the lining of the small airway, constriction of the smooth muscles in the walls of the airway, and increased mucus production. So the diagram there indicating normal airway is showing us the lining's nice and thin, the lumen of the airway is open and unobstructed, the muscles in the walls of the airway are nice and relaxed, all good. On the right is the airway during an asthma flare-up or attack, and you can see that dramatic change. Inflammation of the lining of that airway, changing the structure of that airway and narrowing it dramatically from the inside. The bronchoconstriction of the muscles in the walls of the airway, narrowing from outside the airway, and that thick mucus there, which is an obstruction in itself in the lumen of the airway. And then the diagram in the middle is talking about a person's airway that has had asthma, and then indicating there that that inflammatory process is still, there's changes to the walls of the airway and the lining of the airway in simple terms, and that can re-trigger at any time. And this is really the underpinning reason for ongoing inhaled corticosteroid therapy in medication therapy in asthma, that we need to be able to control that airway inflammation. So the characteristics of asthma, we've mentioned that it's a chronic inflammation of the lining of the small airways of the lungs, and that's associated with the airflow obstruction. When you have a listen to the chest of someone with acute asthma, you can hear wheeze maybe, you can sometimes hear the crackles of mucus, and those can be widespread and variable. So we need to remember that parts of the lung can be affected, but maybe not all of the lung. And those symptoms can be reversible spontaneously or with treatment. And that's another reason that people can get complacent with their symptoms. They can think, oh, I'm a bit short of breath today, or I feel a bit tight in the chest. And then the following day, perhaps that's resolved spontaneously. And so they wonder if it was real. The symptoms of asthma are very common ones: wheezing, shortness of breath, cough, and chest tightness, and can vary for people in severity and depending which symptoms they actually get. The triggers for asthma are wide and variable, and you would know that they can be different for everyone. So some people can identify their triggers quite clearly and others may not be able to do so. But as part of the history taking, we really try to help people to identify triggers, and we can do some investigations towards that, which I'll talk to you soon. And the reason for that is that way we can perhaps avoid or at least help people to manage those triggers, and that will help improve asthma control. So one of our mainstays of asthma treatment is to achieve well-controlled asthma for people. So when we're thinking about triggers, some triggers are unavoidable, and in that category always comes exercise. So in my clinics, people will say to me, oh, I'm pretty good with my asthma management as long as I don't try to do too much. And when I explore that, I always say, well, you know, lungs are quite lazy things. We need to actually use all of our lungs. We need to be exertional. We need to do enough exercise that actually gets your cardio rate up a bit and gets your respiratory rate up a bit. So we don't want people avoiding exercise, and we have to be able to help them manage exercise-induced asthma. We can not avoid, but we can hopefully manage respiratory tract infections. There's certain medications that interact and can increase or trigger asthma. So the common ones are the non-steroidal anti-inflammatories such as aspirin, the anticholineases there. Other comorbid medical conditions can really affect asthma, and allergic rhinitis comes top of the list. They're like little cousins to each other in terms of inflammatory conditions. But gastric reflux is another one, silent gastric reflux. The symptoms can mimic asthma or be certainly make the asthma symptoms worse. And not forgetting the psychological factors, stress, extreme emotions, hormonal changes and pregnancy can also trigger asthma. The avoidable triggers at the top of the list always come cigarette smoking or any form of smoking. So always when we're dealing with anyone with any respiratory conditions, we're asking about smoking, smoking history, and we're encouraging and supporting people to quit smoking if we possibly can. But, you know, cigarette smoking is highly addictive, I understand, but the more we can do to help people not to smoke, the better and more well controlled their asthma will be. But other avoidable triggers, or we may be able to reduce exposure, are common allergens such as pets, cats, dogs, horses, house dust mites, pollens, moulds. Other irritants such as perfumes and sprays, environmental smoke, thunderstorms in springtime are a problem for some people, and that's pollen related. But, you know, other types of irritants are sudden changes in temperature. So going from a very cool air-conditioned home, for example, outdoors to, you know, a 40+ degree day, sometimes those temperature changes really irritate airways. Certain medicines, as we've said, so we need to always be aware of other medications or over-the-counter products that people might be taking. And then some people not that many, but some people do have dietary triggers to their asthma, and they may be related to the food chemicals or additives, or the food itself, or the thermal effects of the food. So very cold or very hot can affect or can trigger asthma. So I just wanted to talk for a second about adolescents. I know this is an adult asthma update, but adolescents fit into this category in terms of treatment. So the handbook refers to adolescents as people aged approximately 12 to 18 years. So in terms of asthma diagnosis and management, under 14 years, we would perhaps use diagnosing and management for children as the guidelines, but from 14 and upwards, we would use the guidelines for adults. And understanding there that some 14-year-olds are adult in stature and frame and body size and may definitely benefit from being managed as an adult. So just be aware of where adolescents may fit in terms of treatment choices. But adolescents also pose their own challenges in managing, and not just with asthma, but in all chronic diseases, I guess. So it's a time of rapid growth and change, both physically, cognitively, emotionally, and socially. And this can mean that people will try risky behaviours such as smoking or changes to eating habits, physical inactivity, drugs, alcohol, those types of things. And this can affect their health and well-being. Adolescence is a risk time for mental health issues to emerge, and that can cause difficulties with management as well. Asthma can worsen or improve during adolescence. So some people will say that they've had asthma until puberty and then it settles down, and for others it's the other way around. It worsens once they get into those teenage years. A really alarming statistic is that less than 1 in 5 adolescents have a written asthma action plan. And they are in that weird space where they're very technological and they may not want a paper plan, but it's perhaps a time to really talk to them about what sort of plan would make sense to them and what plan you might be able to use that they will refer to. Excuse me. Other research tells us that only 28% of adolescents have ever discussed their asthma with a GP in the previous 12 months. So we know that we like to review everyone with asthma at least once or twice a year. So adolescents are a group to be really keeping an eye on. And we also know from studies that adherence to the preventer medication is quite poor in this age group. So that can lead to poor asthma control, of course, and greater risk of flare-up. So how can we help them? Well, we can arrange to see them alone for part of the consultation if that will help. We need to be careful of privacy and confidentiality issues in this age group. So, you know, they may not want to discuss smoking in front of their parents if their parents have come to their consult with them. So just be aware of that. Assess for any psychosocial issues that might affect their asthma management and help them with that, and may be able to refer to appropriate services. So we just need to be really aware and sensitive, I guess, is what I wanted to bring up. Checking inhaler use is really important, talking about why it's important to stay on your medications and providing a written asthma action plan if we possibly can. So how do we diagnose asthma? I'm sure you're all familiar with this chart. That is part of the handbook and it's available to you in the handbook. So we think about taking a really great history for people. We'll do a physical examination. Hopefully we'll be able to do some diagnostic testing right in your clinic with spirometry if that's appropriate for you. We can do other investigations, allergy testing, IgE, bronchial challenge tests, and we may need to even do a treatment trial, and that's not that uncommon. But we need to really work hard to make sure that we're getting those variable symptoms that people may come in with that are suggestive of asthma. We need to try really hard to get that right if we can. So when we talk about history for asthma, we ask about the symptoms, of course. How prevalent are they? When do they occur? How severe are they? What settles them down? How long have you had them? We ask about history of a family history of asthma and allergies. We ask about history of allergic rhinitis, which often precedes asthma. So in some people where that response has occurred quite early, we would have a history of eczema perhaps in childhood. Baby may go on to be allergic rhinitis and or asthma in childhood. And then perhaps just go on to develop asthma in adulthood. But allergic rhinitis is another condition that people just do tolerate the symptoms of, so it's always worth asking about that. Family history of asthma and allergies, only first-degree relatives. We don't want to go back to great aunt, somebody or other, parents, siblings or children, because although there's been no genetic link to asthma at this point in time, there's certainly a strong family history of asthma that can happen. We would ask about triggers in the history. Do they know the triggers? Do they know what causes it? We always take a good thorough smoking history, how long they've smoked for, if they've been a smoker at all, have they quit? Do they need some support to quitting? We can also ask about exposure to passive cigarette smoke or maternal smoking during pregnancy if people do know that. We would do a physical examination, so obviously observing their breathing and, we'll talk about acute asthma management, but often people will come in and see you and they're completely well. So there may be nothing to see by observing their breathing. But we would have a listen to the chest, of course, to listen for any wheeze, which is suggestive but not necessarily diagnostic of asthma. We'd look at the shape of the chest and we'd observe for signs of allergic rhinitis. So things like sinus congestion, dark circles under the eyes, those types of things. Diagnostic testing, as I mentioned, spirometry, we've got to be very aware during COVID that there's some restrictions to spirometry, or at least precautions and infection control guidelines that you should be aware of. And those are available on the NAC website and in the handbook if you're looking for those. But spirometry does assess airway function, as you know, so we would do pre and post bronchodilator spirometry, looking to see if there's some bronchodilator reversibility. And over 200 mil and 12% increase in FEV1 or FVC on spirometry is diagnostic of asthma. Spirometry can be performed in children over about 6 or 7 and most adults. But of course, it may be normal if asthma is well controlled at the time of testing or if people have used medication. So just be aware of that. Peak flow is no substitute for spirometry. It's very unreliable, I guess is the word I'd like to use. It depends on how people use that meter, how old that meter is, where they've stored the peak flow meter. So it's not something that we would be using as a diagnosis at all. And I'll talk further about the COVID infection control guidelines for spirometry later on in the presentation. We can do further investigations, as I mentioned, so skin prick allergy testing or the RAS testing, specific allergy testing, that we can help people identify pollens, grasses, pets, all sorts of things are available now. Challenge tests are available in lung function laboratories, and this is where the symptoms of asthma are actually induced with a chemical, usually methacholine or something similar to that. And so we would induce asthma and then we would reverse it, and that's diagnostic. And that can be useful where people are very difficult to diagnose. That's not for everyone, but that can be useful for some people that are very difficult to diagnose. Other tests such as chest X-ray are not really helpful. You can't see the small airways of the lungs on chest X-ray. So it's only really useful to exclude other conditions, you know, such as infections and things like that. Just mentioning IgE levels, there's a lot of work being done in research around IgE levels now. So those above 300 millimoles would warrant some further investigation, and that is an indication of airway inflammation. So that's just something to be very aware of. And there's treatments available for those with severe IgE asthma as part of monoclonal antibody therapy. So asthma is more likely if the symptoms are really identifiable as seasonal or recurrent, if they're worse at night or in the early morning. As I said, if we can identify some triggers, and the common ones there are the exercise, the irritants, allergens, or viral infections. And if those symptoms are rapidly relieved by an inhaled bronchodilator, usually a short-acting beta-2 agonist, then that really gives you an idea that there's that bronchoconstriction going on. Asthma symptoms may begin in childhood, not always. Asthma is more likely if FEV1 is lower than predicted without any other explanation, and as I mentioned, the eosinophilia or the raised IgE without any other explanation. But we're remembering about other conditions that can confuse us in the diagnosis of asthma. So if you think about wheeze, shortness of breath, cough and chest tightness, there's other things, of course, that we would need to be thinking about. And often cardiovascular disease comes to my mind. So, you know, CCF, that can certainly cause those symptoms that we're talking about. It's always worth remembering that although cough can be a predominant feature of asthma, it's rarely the only symptom. So if someone just presents with recurrent cough, that's worth further investigation as well. But we need to think about other things. So uncontrolled allergic rhinitis is a real issue. And please excuse my throat clearing, but yes, I've had quite a high allergic day today in my garden. So I've got a bit of a tickly throat. But things, as I mentioned, like reflux, morbid obesity, for example, postnasal drip, enlarged thyroid. And then with exercise-induced respiratory symptoms, we need to try and work out if it's just normal huff and puff or if it is actually asthma. So I'll just take a pause there for me to have a drink of water, but just wondering as well if there are any questions at this point in time.
Mark, we did have a question regarding the advice regarding diagnosis given the risk of spirometry with COVID. And I know that you were going to talk about that later. Do we simply do a trial of treatment initially?
Well, spirometry, thanks Bertha, spirometry is able to be performed in primary care now as long as you're observing the level 1 PPE requirements that are mentioned. And there's an information sheet on the NAC website about the infection control recommendations for performing spirometry in primary care. And there's also some information in the handbook, of course, about performing spirometry in primary care. So spirometry should not be performed on anyone if they have symptoms, respiratory symptoms indicative of COVID. They should be, of course, advised to go and have a COVID test. In anyone that is febrile, in anyone that's been in close contact with a positive COVID person, of course, and then if they have answered negative to all of those screening questions, then you may feel confident to perform the test on them. But that's when within your own practice, you need to be aware that you should be performing spirometry with level 1 PPE, meaning mask, face, eye protection, so glasses or face shield, perhaps a gown and gloves if that's your preference. Otherwise, accurate and good and thorough hand washing, making sure that it's in a single room that can be cleaned, making sure you're using inline filter, viral and bacterial filter for the spirometer. All those types of things that we now know are so important in reducing aerosols. And spirometry is, of course, an aerosol generating procedure. So, as I said, all of that information is available on the NAC website and in the handbook. So there's a sheet you can download about infection control for spirometry. Okay, moving along now. So we're going to just talk about the management principles of asthma. And as I said, asthma is a chronic disease, and so we need ongoing care. It's not about just treating the acute flare-up, and of course we have to do that when they come into the clinics, but it is an ongoing condition, and we need to be in a position to support people with self-management education for asthma, because that's the key to them continuing on their inhaled corticosteroid or medication treatment. And it's also about making sure that they know what to do at home or wherever they are if their symptoms do recur. And the main way we do that is through education and having an accurate asthma action plan for that person. So for all chronic disease management, we consider lifestyle issues, medical management, and then managing comorbidities for people. So lifestyle issues, always with respiratory, as I said, and with asthma, it's no different. We encourage everyone to cease smoking if they are smokers. And there's an enormous number of resources available about smoking cessation, and I won't talk about them here. I'm sure you have access to them. You probably know what works for you and how you like to present that information to your patients, but smoking cessation is super important for anyone with asthma. And then eliminating passive exposure. If that person's not a smoker themselves, but they are exposed to passive cigarette smoking, then we talk to them about ways to reduce that. Avoidance strategies for their triggers, super important, as I've covered. Healthy, well-balanced diet, hopefully leading to ideal body weight. So just physically, if we think about weight around the abdo, where we often, gather it as we get older, we certainly don't want people doing that physically. It just inhibits the lungs. So we want people to be healthy and well in their ideal body weight. We always talk to people about exercise and activity levels. As I've said, we want people to be active. We want people using their lungs well, and we want them to be able to be, enjoying their exercise. We need to talk about stress management if that's a trigger, and helping people with that so that they're comfortable and their asthma is well controlled. Those resources that are on the screen are NAC resources talking about lifestyle issues for those with asthma if you want further information on that. Just talking now about what's really new in asthma management, and I hope that that's not the case. I hope you've seen this diagram. This was released when the Australian Asthma Handbook was updated in 2020. So this was the new figure for selecting and adjusting medication management for adults and adolescents in Australia. So in asthma as a chronic condition, we do have medication management, of course, and you'll see there that it's set up as a stepwise up and down the diagram. So step 1 is very few patients would be managed with as needed SABA alone, short-acting beta-2 agonists, generally Ventolin or Bricanol. And the reason for that is because those that become highly dependent on their short-acting beta-2 agonists are actually at greater risk of a severe asthma flare-up and death. And the recent research has certainly indicated that. So the recommendation is now that very few people are actually managed, and only those that are experiencing symptoms less than twice a month and have no risk factors for a severe flare-up. We need to highlight that everyone with asthma, we should be assessing their individual risk factors and comorbidities to assess their risks for flare-up. We need to advise and prescribe reliever therapy, provide education, provide a written asthma action plan, and talk about those factors that can influence their asthma within their lifestyles, as I've covered before. Step 2 are most patients, and this is where the change came about, where most patients require regular daily maintenance therapy, inhaled corticosteroid in low dose and SABA reliever as needed, or now we can use budesonide formoterol in low dose as needed for those with mild asthma. So that's been a change. Step 3 would be some patients where we would be talking about combination therapy there. So those that are not controlled on step 2 may need to step up, and they would be managed with perhaps combination therapy as maintenance and reliever, or combination therapy and short-acting beta-2 agonist reliever. Step 4, very few patients which are on medium to high dose medications, and if they're not well controlled there, step 5 is that they're referred to a specialist for add-on treatment, and now they are usually the monoclonal antibody therapy that I was talking about. Really important to remember that the steps go up, 1, 2, 3, 4, 5, but they can also come down. So when people are well controlled, you may be able to monitor and manage them and step them down from step 3, perhaps to step 2. So just to discuss levels 1 and 2 in further detail and make sure that you can see that quite clearly on the slide there. Just once again reiterating, very few people needing as needed SABA alone, and most patients now, the recommendation is that we're starting with a low dose inhaled corticosteroid therapy with SABA reliever as needed, or budesonide formoterol low dose as needed. And in Australia, that is Symbicort, 206 in the Turbohaler, 103 in the Rappahaler. That's PBS listed for as needed use, or the Duo-Resp Spiromax 206 for those aged over 18. Once again, I've spoken about this, so that's just talking about the or. So regular daily ICS with SABA as reliever or the combination therapy as needed. So our step-by-step management for people with asthma, medication management this is that, as indicated with our guidelines there, most people with asthma should be on a preventer therapy. We start that medication at the level most appropriate to the asthma severity. So that's where we would be looking at the classification and severity of the asthma, how frequent their symptoms are, how severe their symptoms are, and what treatment level we think we would start with to bring that under control. And then, as I said, we would step up or down as needed, as per those guidelines that we've just been talking about. Longer term, once people are stable and the asthma is assessed as well controlled, the goal is to decrease the treatment to the least medication necessary to maintain good asthma control. We may need to remember that we can refer on to respiratory specialists if the response is poor to the treatment regime or unexpected from the treatment regime. So don't forget that we, in primary care, we've certainly got specialists that we can refer to. All patients need reliever therapy and all patients need a current written asthma action plan, which is individualised to them so that they know what to do should their symptoms occur. So what do we mean by high, medium and low dose ICS in adults? This chart's available to you in the Asthma Handbook as the guidelines, and I'm not going to go through each individual medication at the moment, but the idea of this slide is to make sure that you understand 200 milligrams in one is maybe a low dose, but not necessarily in another. So just please be aware, it's impossible to perhaps memorise all of this, but the resources are available for you to check the doses and make sure that you are commencing people on low doses and that you're trying to maintain and keep people on the lowest possible dose possible to control their symptoms. I'm sure you're all really aware of this wonderful resource, the Asthma and COPD medication chart, which is published by National Asthma Council. So it's got the classes of medications there. It's got the pictures there to help you identify the medications and to look at all the devices. It's got the scan function there down in the left corner where you can scan onto there and it will link directly to the National Asthma Council how-to videos so that you can use that as a teaching resource in your practices to show people those how-to videos which demonstrate the correct device use technique. When I look at this chart, and I know it's pretty overwhelming if you're not familiar with all of the medications that are available, but I just see it as such a wonderful, we're so lucky really that we've got a lot of variation of medication available here in Australia. We've got a lot of device variation, and so we've got the absolute opportunity to be able to match the best class and type of medication and device to suit the person in front of us. And that's all about choice, so that's fantastic. Remembering that those ones over on the right there are generally COPD medications, although of course Spirometry, Respiratory is available for those with severe asthma. So just as a summary, managing asthma in adults, we need to confirm the diagnosis. We want to assess the asthma control, and we do that by assessing the symptom control and the risk factors. We want to manage any comorbid conditions that are affecting asthma, particularly allergic rhinitis. So we, may mean that people are using their inhaled nasal, I nearly stumbled there. Their inhaled nasal sprays, their corticosteroid nasal sprays to manage the inflammation in their upper airway, and they're using their inhaled corticosteroid therapy for their asthma to manage the inflammation in their airways. We want to have regular review of these people, and for a lot of reasons. We need to make sure that what people perceive as their well-controlled asthma is well-controlled asthma from our point of view. We want to prevent any We want to be able to adjust their medications if that needs to be happening. We want to be able to provide ongoing education and support. We want all of these information, skills and tools for self-management. So we can continually update and adjust their written asthma action plans. We can educate them in the correct use of their medications and their devices. We can help them with trigger management. We can talk to them about ceasing smoking, exercise, weight, all of those types of things. Just excuse me a second. I'm going to close the window because the crickets are really noisy. I don't know if you could hear that, but all I could hear was crickets going on in the background. Okay, so what are we doing when we're assessing asthma control? Asthma control involves reviewing the symptoms or the pattern of symptoms and severity over the previous 4 weeks for someone. So we don't want to be just saying to someone, oh, how's your asthma been? We want to be quite careful in the questions that we ask them about reviewing patterns and severity of symptoms, and then assessing for risk factors for future adverse events. So anyone that's had a really severe, life-threatening previous event of asthma is at risk of that recurring. Anyone that's had an ICU admission, for example, in asthma, is at a higher risk of another severe flare-up. So that's what we're talking about when we talk about risk factors for future adverse events. We're also talking about behaviours of people. So if there's someone that comes on and off their medications, for example, that immediately puts them into a risk group for a future flare-up of asthma. So when we assess asthma control, we want symptoms less than 2 days a week. We want reliever use less than 2 days a week, excluding those doses that people may use prior to exercise. We want no limitations in activities, and we want no symptoms during the night or on waking, so symptoms at rest. So when we're talking about asthma control, these are the types of questions we're asking people. This is the chart that's taken from the handbook there that's talking to you about what we consider is well-controlled, good control of asthma, partial control and poor control. And once again, I'm not going to read through that for you, but it's just talking about an escalation of those types of symptoms. So for example, in well-controlled, we would expect daytime symptoms less than 2 days of the week. Anyone that's experiencing daytime symptoms more than 2 days a week, then they've got partial or poor control depending on where they sit. So those resources are all available for you in the handbook. So we would be asking questions of folk, you know, how often are you experiencing your symptoms? When is that occurring for you? How frequently are you using your reliever? When did you last need to use it? How many times did you need to use it? How do you go with exercise with your asthma? Is asthma waking you up at night? Those sorts of things. So our reasons for poor asthma control, and we've perhaps talked about this as we've covered other topics in the presentation, but there are medication-related issues, of course. So incorrect device technique comes at top of the list. Nobody deliberately uses their device incorrectly. They've either slip into poor habits or were never taught the correct technique in the first place. And that's really unfortunate. And when I see people that, when I ask them to demonstrate their devices and they're doing it incorrectly, you need to be very gentle and careful about how you explain that, because, you know, as I said, no one deliberately does that or uses it incorrectly. But people may have poor adherence to their therapies, so they stop it themselves, they think they don't need it, they change the dose themselves. Maybe the incorrect dose, so when we're thinking about where we're starting on our diagram and our step diagram, it may be that they actually do need a higher dose to actually bring their asthma under control. Or they can be over-relying on their reliever therapy if they're using that. So, you know, they know their preventer's got steroid in it, they've never had that explained to them, that it's completely safe to use inhaled corticosteroids, and they think it's better to use reliever rather than preventer therapy. And that is one of the common reasons for poor asthma control. And we're not going to be controlling the inflammatory process in the airways of the lungs. with short-acting reliever therapy. Or another medication issue, of course, is medication interaction. There may be uncontrolled trigger exposure. So commonly there we talk about allergic rhinitis as the main one, but it may be other things. So they can have exposure to chemicals, perhaps at their workplace or wherever. They may have continued smoking, for example. No asthma action plan or no regular review of their asthma is a reason for poor asthma control. So they don't understand the pathophysiology of asthma. They don't understand the importance of managing it well themselves. Or it's a diagnostic issue. It's either more severe than we've actually diagnosed and they do need ongoing treatment and add-on treatment, or it's not asthma at all. And just to mention there that if people are on multiple medications, then you can consider a medication review for them, and that might really help to sort out what else they're using if there are medication interactions going on. Just a little thought about educating people and exploring patient perceptions, because we talk about patient-centred management and self-management a lot in chronic disease management, but it's not always as easy as we'd like it to be to actually put into place. But we really encourage you to be offering people with asthma good self-management education and focused on their individual needs. And we've talked about that in terms of triggers and medication and device technique, etc. And then reinforcing that need of a personalised written asthma action plan. So something that's actually very personal to them. It lists their own medications that they're taking, identifies their symptoms and helps them to make a decision about when the symptoms change, what they need to do. So every asthma consultation is an opportunity to review and reinforce and extend knowledge and skills for people, except those when they come in with acute symptoms, when of course we need to be managing the acute symptoms. And that's why review appointments are so very important. Education can't be done in just a single visit. So it's about talking, as I mentioned, about asking those right questions. And these statistics are very surprising, I guess, to some people. So 78% of Australian people with asthma believe they're very well controlled. In fact, 13% of people are well controlled when this study was done. And that's quite shocking. So it really means that people, their perception is that they feel their asthma is being really well managed, but if we look at it from a clinical perspective, that's not actually the case. And about 58% of people were using their reliever at least twice a day. And I'm sure you're aware of the recent research that's been done into overuse of SABA relievers and the risks that that creates for those with asthma in terms of a severe asthma flare-up. So that's a lot of people that are using their reliever at least twice a day, when we know that well-controlled asthma would say they should be using their reliever less than twice a week. So we don't want to just say, how's your asthma? Because most people will say, oh, fine, thanks, Marg, all good, no problems. We need to ask questions like, how many times have you used your reliever puffer? How many times has asthma woken you up at night in the last 4 weeks? How many times have you been short of breath? Those types of questions. And I'm sure you've got your own way of asking these things, but it's just a reminder. So asthma reviews, people often ask me this question, how frequently should we be doing asthma reviews? Well, that does depend on how well controlled and how well managed that person is. So, it may be twice a year if people are really stable and well controlled, and you know that they're using their devices well, and you know that their asthma action plan is current. But for those that are less well controlled, or those that are recovering from a severe flare-up of asthma, then we would want to be doing those reviews more frequently. And that might be, 3 monthly for 3 to 6 months, and then you may be able to extend that out to 6 monthly or 12 monthly. For those that have allergic rhinitis, it's a great idea to review them prior to allergy season. So around the July-August in southern Australia, when we know the ryegrass causes a real issue around October-November, but that's a really good time to bring them in, talk about their asthma control, but also double check how their allergic rhinitis is going. If we're going to change doses or types of medications, then it's very important to review people quite early on after that. So within 2 to 4 weeks of changing medications, just to check in how they're going, if they're tolerating it, if they've got side effects from it, and if they've continued to use the device correctly. Once again, the flip side, if we've decreased medications, then we would also need to review 4 to 6 weeks after that to assess their control and make sure that they're stable on that lower dose. We encourage review within 2 to 3 days of a hospital presentation, and most hospital discharge plans for asthma now say that. Please see your GP within 2 to 3 days. But then from a primary care perspective, we would be really hopeful of seeing that person again in about another 4 weeks so that we can make sure that they're controlled on the medications, or we may be hopefully able to reduce their medications by then, and they may need a rewritten asthma action plan by then if we're going to be changing their medications. So there are some validated questionnaires to assess symptom control, and they're available in the Asthma Handbook at that link that I've got there. And part of asthma review may be that we will perform spirometry to monitor lung function, and we may be able to use the results of that spirometry test to monitor the response to treatment. Another issue in primary care we all talk about is the confusion in language around plans. So we've got GP management plans, team care arrangements for those with chronic diseases. We can call them by that technical name, GP management plan, team care arrangement, or we can call them care plans. And we've also got written asthma action plans. And this diagram, which came from Associate Professor Helen Riddell, I think is a really great way of having a little think about that. So our asthma first aid plan is for community use. Our asthma action plan is for us to be using in primary care to help people monitor and control and know what to do. And then our chronic disease management plans are a longer term management plan where we will write individual goals and perhaps use that as a referral tool as well. So written asthma action plans. We all talk about written asthma action plans, and hopefully you're all doing written asthma action plans, but sadly the statistics and data in research doesn't support that. So very few people, less than 50% of adults, have actually got a written asthma action plan. We do better for children, and that's partly because schools and childcare centres demand them. But written asthma action plans improve outcomes, and we've talked about that as I've been going through the presentation for you. They help people to recognise worsening asthma. They help people to identify their symptoms and know what's normal for them and what's not normal for them. And then the plan gives advice for adjusting medication. And the outcome of that is that those people have improved asthma control. They know what they're doing. They know how to manage their mild flare-ups. So hopefully they miss school and work less often, and that when we assess their asthma control, they have an improved symptom score. Asthma plans also give advice on when people should seek medical help and advice on when to call the ambulance. So NAC always has stipulated that everyone, whatever age group with asthma, needs to have a current asthma action plan. So just touching on again that they need to be personalised, and there's many templates available, and I can show you a couple in the coming slides, but we don't want to just spit something out of the computer. We need to be sitting with that person, talking to them about the symptoms they experience, making sure the plan is in a language they understand, so not using any acronyms. We don't want to say SABA, PRN, for example. We need to be writing that out in a language that they understand. 2 puffs of Ventolin with your spacer, 4 hourly as needed, for example. We need to provide advice about when those symptoms change and what to do. Talk about emergency steps, as I've said. For children, it's really useful to include emergency contact numbers, and perhaps for some adults as well. There's lots of resources available for you on writing written asthma action plans, so please have a look in the handbook for those. These are some of the plans, as I said. So National Asthma Council has the action plan there on the left. It's colour-coded in green, orange and red, which a lot of other plans are as well. And that makes a lot of sense to people in the community. Green indicating when they're well and well controlled. Orange, caution, is indicating when symptoms are changing and they may need to adjust their medications. And then red is when their symptoms are becoming worse, they need to seek medical advice or they need to dial for an ambulance. All of the software programs have asthma action plans as part of them. So please look into your software and see where it is, see if it's a template that you like to use. You can use shortcuts to make sure the medications people are on come straight into that plan. Other organisations have asthma plans as well, Royal Children's Hospital, for example, or Asthma Australia. Excuse me. There are some culturally appropriate plans that have got some diagrams on. They are a bit outdated now. They were developed in the Northern Territory or Northern Queensland, and so they're not got all the medications on, of course. And on the right there, the Symbicort Smart Action Plans have been updated to now include the combination medication used on an as-needed basis. So if you need those new plans, they're available on the NAC websites or from your AstraZeneca reps. So whatever plan is appropriate for that person, whatever template you like to use, please remember that we want everyone to have a written asthma action plan and we want that to be personalised. First aid plans are different again. Access and treatment for asthma out in the community. And I'm sure you're all really aware of this, commonly known as asthma 4x4x4. So giving 4 separate puffs of reliever therapy via a spacer, 4 breaths per puff, waiting 4 minutes, monitoring the symptoms. If the symptoms have persisted, then you repeat steps 1 to 3. If there's still no improvement after that 4x4, then you continue to administer therapy with that same regime, but then you're calling for an ambulance and getting some help. Excuse me. Bricanol as terbutaline can also be used as part of an asthma action plan, and that's down the sides of the plan. And of course, now people may actually use their combination budesonide formoterol if that's what they're using as reliever therapy. So those charts are available on the NAC website, but it's first aid community. It's certainly not what we would do for managing asthma in a primary care setting. Excuse me. So I'm just going to talk to you now about acute asthma management in primary care settings. And we generally do get some warning of an asthma flare-up, and often this will only come out when we get people back for that review after a flare-up, and we say to them, you know, what was happening in those few days before you landed in hospital, for example. And sometimes they will actually know that their symptoms had actually changed. What we would hope as health professionals is that they've actually followed their asthma action plan. So if they're experiencing more symptoms than usual, or the symptoms are more severe than usual, that's an indication that asthma is flaring. If they're needing more reliever than usual. So remember that well-controlled asthma says they only need their reliever 2 or less times per week or days of the week. So if they're needing it more than that, that's indicating that their asthma is flaring up. Waking at night with asthma symptoms is a real indicator. Or asthma suddenly interfering with their exercise where it previously hasn't been. As part of their plan, as those symptoms worsen, if they're needing their reliever again within 3 hours, or asthma is interfering with normal day-to-day activities, not just exercise, then they need to refer to their asthma action plan, follow their asthma action plan. If they're not comfortable with that, then they need to come into the doctor. So our management in general practice revolves around taking a primary assessment, of course, deciding if it's mild or moderate, severe or life-threatening, and then acting or responding accordingly with our therapy. We monitor with pulse oximetry. We use bronchodilators. We have a secondary assessment then to decide what we're going to do, as in send that person home or send them to hospital, and then ongoing management and follow-up post the flare. So our primary rapid assessment, and once again, these charts are taken from the Asthma Handbook. Those with mild to moderate flare of asthma can walk into your clinic. They can speak in whole sentences in one breath. They know that their symptoms are a change from normal, but they can speak in phrases, and their oxygen sats are usually not too bad. In a more severe presentation, then they're obviously short of breath and the accessory muscles of respiration will be in use. So they may have tracheal tug, intercostal rib recession. Usually they may be cyanotic or becoming a bit dyspneic. They've got obvious respiratory distress and their oxygen sat levels have dropped to between 90 to 94. And then life-threatening, of course, they're in extreme respiratory distress. Could be poor respiratory effort and then very soft or absent breath sounds on auscultation. They're exhausted. They can be very distressed and anxious, and their oxygen sats are very low. So our rapid primary assessment is giving us an indication of where we're going to start our treatment, of course. So management of a mild moderate flare-up is with short-acting beta-2 agonist reliever, generally salbutamol that you've got in your practice, by a metered dose inhaler, puffer, and a spacer. So with adults, we would be using 4 to 12 puffs, and we would be monitoring that person. We would repeat those doses every 20 to 30 minutes in the first hour as part of monitoring their symptoms. So if their symptoms haven't resolved after the first application of medication, then of course we would be needing to re-administer. So it is salbutamol via puffer and spacer at a mild to moderate flare-up. We'd be monitoring the oxygen saturation levels, as I said, and maintaining those between 93 and 95 at least. So you may be needing to administer oxygen therapy to achieve that level of saturation. And you're monitoring and observing this person for at least 3 hours in your practice, depending on how the response has been. So that's where that secondary assessment sort of comes in. As time goes on, you're assessing the response to the therapy, the amount of therapy you've needed to use, their respiratory symptoms, their oxygen sat levels, and then making a decision. What we hope is for a mild to moderate flare-up that level of therapy will, of course, bring them under control, and you'll be able to monitor, observe them, and then send them home with an updated plan and medications to manage that flare-up. We do say to consider oral corticosteroid therapy within that first hour for most people, so that's something that you can instigate in your primary care setting. If there's limited or no response to that treatment and you've assessed their symptoms and they're not getting better, then you may be advised to call the ambulance 000 right then, depending on your location. In metro areas, we can usually depend that an ambulance will come quite quickly, but in rural areas, of course, that may not be the case. We can continue giving salbutamol via puffer and spacer if that's appropriate, but you may need to use nebulized salbutamol only if the patient is unable to actually breathe through the spacer. We need to be very aware through COVID that nebulized therapy is our last resort. It's contraindicated through COVID for obvious reasons. We're all very aware of what's happened in Victorian hotel quarantine settings with nebulized therapy. So we need to be very careful of when and how we use nebulized therapy during COVID. But generally in acute asthma management from mild to moderate, we would be hoping that nebulized therapy could be avoided. So when does this actually become an emergency? And I'm sure I don't even really need to tell you this. If you've got somebody in front of you and you can see that they're not responding to the therapy that you've been administering and they're increasing in respiratory symptoms and becoming more severely, just as I've said, they maybe have limited ability to speak to you now because of their level of dyspnea, their oxygen sat levels are dropping. Their response to reliever therapy is not happening and the symptoms are getting worse, then we need to understand that this is an absolute emergency. In community, when we're talking people through their asthma action plans, we need to make sure that they just know that if they've used their reliever and it's not working for them, then they leap straight to dialing 000. They don't have to think about anything else. So when they're in community, they start their treatment, and if it's not effective for them, then they get some help straight away. It's well documented, the treatment for acute asthma for adults and then life-threatening acute asthma for adults and children. And these charts are available in the Asthma Handbook and can be printed off and put on your treatment room wall if that's what you'd like to do, or used as a topic of conversation for a meeting in your clinic, a clinical meeting amongst the practitioners. That's a really good idea. How would we manage acute asthma in our primary care setting? Have we got the medications available? Does everyone know where it is? Those types of things. It's a really good, they're really good resources for you to look at and use in terms of managing acute asthma. So just touching on emergency management of life-threatening episode or flare-up for an adult in your primary care setting. This is when we may need to give oxygen-driven salbutamol via nebulization, and the dosages are listed in the handbook there. But for those over 6 years of age, this is in a really life-threatening situation. We would use 2 5-milligram nebules as a continuous nebulization of salbutamol. We're monitoring and maintaining oxygen, so you would be giving oxygen, of course, to these people with a target there of levels between 93 and 95%. We would be arranging immediate transfer to the ED department. If the response to salbutamol is poor, then you can add the nebulized Atrovent at 500 micrograms in with the Ventolin. If there's no improvement or that is worsening, you may want to administer IV magnesium sulfate, and that's given in a dilution over a 20-minute period. The levels and guidelines for those are in the handbook. If that person responds to this treatment, then you would consider reverting back to salbutamol via MDI and spacer, or using intermittent nebulized therapy every 20 minutes. And that's simply to reduce side effects of the therapy, but also, as I said, because we're always trying to avoid nebulization if we possibly can, particularly now during COVID restrictions. So once we've treated that person, we've either sent them off to hospital and they've been treated there and they're discharged home again, or you've managed the mild to moderate or even more severe flare within your practice. You've then observed them for that period of time, you've stabilised them and they're off home. We certainly want a thorough and good review period, and that may be within the next 24 hours or post-discharge. As I said, most hospital discharge plans now do say review in your primary care setting within 2 to 3 days, and then another comprehensive review within 2 weeks. So when they come for that first appointment, it's really a great opportunity to book them back in for another review. So that's an opportunity to talk about that flare, try to identify some triggers, what actually happened, talk about the medication. Were they on their preventer? Were they taking it? Were they taking it correctly? Did they use their reliever correctly? Did they follow their asthma action plan? People are very anxious and distressed after an acute flare-up of asthma, and they really do benefit from some really good support and having their doctor or respiratory nurse there to talk them through it and help them understand what happened and what to do if that happens again. We want to provide an accurate written asthma action plan, and understanding that a couple of weeks post an acute flare-up, the medications that they're taking will change. The doses will reduce, hopefully, so their action plan needs to be changed. We may want to do some spirometry to monitor their lung function, and then we will continue that review process as I discussed earlier in the presentation. Just another little chat about Tele Health, because during COVID, we've utilised Tele Health a lot in primary care, and a lot of patients have found that that's been an excellent way to keep in touch with their GPs, and GPs have also found it an excellent way to keep in touch with patients. So it can be utilised, of course. What can you do over the phone? Well, you can ask your asthma control questions and do an asthma score check. You can check their written asthma action plan. You can talk to them about their supplies of medication, scripts, etc. Talk to them about their relievers. If it's a video call, you can check their device technique. You know, telehealth is really come into its own during COVID, much like webinar and online education has. And I'm sure you probably know better ways than me to be utilising telehealth. If you need information on that, please go to MBS Online. So just a little moment talking about asthma and COPD and COVID-19, so all respiratory conditions. Both the Australian Handbook and the Lung Foundation websites have updates relating to lung conditions with COVID-19, so I encourage you to access those. We strongly encourage that everyone has a written asthma action plan. We strongly encourage you to be aware of the infection control recommendations for performing spirometry in primary care. Strongly encourage you to understand and avoid using nebulizers, so a well-fitting mask if you need, and spacer with MDI is preferred for all treatment within your clinic, but also at home if we possibly can. Those with asthma should continue on their current medications, including their inhaled corticosteroids. As with all flare-ups, we should only be using oral steroids for severe flare-ups as indicated. Really a great time to remind people not to share their medications spaces, even between family members, and remembering that we want to have medications handy. Not so important now that we're out of lockdown and we've got access to our pharmacies again, but people really panicked during lockdown to know that they were going to have enough medications. And I need to really add on to that slide. Now is the time to start talking to people about their immunizations. So of course, Fluvax, very important, pneumovax for those that are eligible for it, for those with respiratory conditions, and COVID-19 vaccination, which is the rollout, has commenced. And remembering that the recommendation is that Fluvax and COVID-19 are given 2 weeks apart from each other. So that ends my presentation tonight, other than to encourage you to look for resources as you may need through the handbook or the NAC website. There's a lot of consumer resources available through the Sensitive Choice website, which is a sub-branch of National Asthma Council. If you'd like to join our health professional network and receive the newsletters, please do that. You can contact us on Twitter and Facebook. And just to acknowledge briefly, there's an expert review group that help NAC to put these webinars together, and those are the health professionals that have been involved in this process, so thanks to them. And I'd really like to say thank you for attending, and please complete your evaluation survey when you get that link. This program, federally funded, which allows us to provide this education, really depends on great evaluation. Every evaluation response is really important, and it allows us to tailor the session to your needs. So that's really important for us if you could do that. And we've just got time now for some questions, and just would also like to bring to your attention that we do offer some other webinar topics. So if you're interested in those, keep an eye on our calendar and let us know, or let your PHN know if you'd like to access one of the other talks. So handing over to questions now.
Thanks, Mark. Excuse me. There are quite a few questions and comments, so I'm not sure if you want to open up your chat, and that way you can see them as well. Some of them are quite long, but I might just get the ball rolling. If you can comment on the role of e-cigarettes in asthma.
Well, e-cigarettes are very controversial, and I would just put them in the same group as all smoking. We would discourage anyone with any respiratory conditions to use e-cigarettes as an alternative to cigarette smoking. I don't think the research supports that they particularly help people to quit smoking. A lot of people buy the solutions that they use in their e-cigarettes online, and there's really, I don't know what's in them, or people don't actually know what's in them. So I don't consider e-cigarettes as a safe form of smoking. There is no safe form of smoking, and e-cigarettes sit in that category.
Great, thank you. What about the link between asthma and the microbiome?
The microbiome?
Yep.
Yes, so there's been a lot of research going on in that at the moment, and I think that's a really interesting and evolving field. So I think that's an area that we need to keep aware of, and read the papers, read the literature, look out for the papers that come out on that. And it's something that's going to be very interesting, and we might be able to help people to manage their asthma by making some changes for their gut biomes.
Great, thank you. And there is a comment there from Philip, if you wanted to have a quick read and then address that. But the next question is the use of biologicals in patients who suffer from severe asthma.
Yes, the biological therapy is available through a respiratory specialist. So in primary care, I think, as the stepwise diagram showed us, that if you have someone that doesn't respond to the treatment as you think, and so they're on medium to high dose combination therapy, they may be on add-on therapy such as the Spiriva, and they're still poorly controlled, and they have raised eosinophilia levels, then they would be really excellent people to refer to a respiratory physician and have a specialist review, because they may be eligible, and the therapies available now may really help them. I've had a couple of people in the clinics where I work that have commenced that therapy and have responded really well, and it's been completely life-changing for them. So I would encourage clinicians that if they feel people don't respond to the inhaled therapy, then certainly to refer on.
Okay. Is it okay to start a newly diagnosed asthma patient on SMART therapy, or should we use ICS inhaler therapy first?
Well, that's an interesting question, because the guidelines do say that we can use the combination therapy on an as-needed basis, or we can use inhaled corticosteroid therapy and short-acting reliever therapy. I always consider that this really depends on how well educated that patient is about their asthma. So I think for some categories of people, SMART therapy is really applicable, really suitable, and really easy for them. And they can manage with the concept that they're going to use one medication as their maintenance therapy morning and night, and use the same medication as reliever therapy. Other people just simply can't get their head around that, or become confused by that, or run the risk of getting the two therapies incorrect, and they end up on the reliever therapy daily and they don't use the other one. So it's really a matter of assessing the person in front of you and making that clinical decision about where you start them.
Great. What happened to the asthma cards?
What happened to the asthma cards?
That's a question in there. I'm not sure what that refers to.
No, I'm not sure what that refers to either. The asthma cards, they must have been some sort of maybe teaching tool or resource tool. I'm not sure, but if whoever sent that question in would like to email me with a bit more information, I can try and follow that up at marg.gordon@nationalasthma.org.au.
Great, thanks, Marg. If there are any questions, please send them through. We might just wait a few more minutes. And Marg, while we're doing that, if you can just have a look at Philip's comment, you might be better equipped to do that one.
Sure, I'll just have a little look there. Yes, so Philip's talking about, I guess once we did touch on this about talking about alternative diagnosing. So making sure that we've actually got that diagnosis right and investigating other comorbid conditions that could be a feature for those people. So he's mentioning there that spirometry was normal, but this person had actually been suffering with postnasal drip. So it's really important to explore all the symptoms that people are experiencing and provide appropriate investigations for that.